My plan here is just to talk about tinnitus in a very general way, the kinds of things that are done to help people with tinnitus, and the kinds of things, some things that are not done, and possibly some things that could be done in the future. Okay? So first of all, this is a definition after Dennis McFadden. So tinnitus, you have to hear it. It's involuntary, not something you're producing intentionally. And it's something in your head. It's not something that you're super sensitive hearing or something else. So tinnitus is a symptom, just like hearing loss. So typically in the healthcare system, you often hear about objective versus subjective tinnitus. I like to talk about tinnitus the way that we talk about hearing loss. So it's either a middle ear tinnitus, it occurs in the middle ear behind your eardrum, or it's a sensory neural tinnitus. That is, it starts in the sensory neural system in your body. How many people here have tinnitus? So a few. Okay. So that's how we think about hearing loss. So it's either a middle ear tinnitus or a sensory neural tinnitus. Most of the people here, I'm guessing, if not all of you, have a sensory neural tinnitus. Okay. Chances are you don't have any abnormal blood flow in your middle ear behind your eardrum, or you don't have any muscles twitching. There's something going on that's not supposed to in the sensory neural system. Okay? So it turns out that about a third of the people have unilateral tinnitus. Raise your hand if you have a unilateral tinnitus in one ear. About half the people have it in two ears. Raise your hand. Okay. About very few number of people hear it in their head. Anybody sort of hears it in their head? Okay. And I've only seen one patient that says they hear it somewhere up there. Anybody know? So I didn't count exactly, but I think we're pretty close to the numbers that we did in the survey many, many years ago. So this is a survey done showing how the age affects the prevalence of tinnitus in males in the blue bars and yellow in females. And this is the percentage of the population. Now this is actually kind of a tricky question because it really depends on how you ask the question. You can get quite different results. But the bottom line is that as we get older, we're more likely to get tinnitus. And that's true in both ages, especially over the age of about 50. And as I always say, especially to professional audiences these days, everybody in this room is going to get a hearing loss eventually. Okay. So most of us are going to need hearing aids. And chances are, you guys, most of you have tinnitus, but even if you didn't, because about 1 in 4 people generally end up getting it, it's either the person on your left or your right or sitting behind you is going to get tinnitus. So it's actually incredibly common. Anybody know what the most common cause is?
Medications.
I'll pretend I didn't. Anybody else know what the most common cause is?
Medications?
Medications is a cause, not the most common. Well, hearing loss is related to it. The most common cause is noise exposure. So noise exposure is the most common cause, by a long shot. So these are people, this is a survey, population at large, and these are people that have tinnitus. And it turns out that about 13% of these people have hearing aids. Almost half of them say they have a hearing loss, but they don't have hearing aids yet. And almost half of them say they have normal hearing. They don't have any problem hearing. Now, this is actually not true. These people do have trouble hearing. They do have a hearing loss, but it's either a very mild hearing loss, or their tinnitus is so prominent, it's so important for them, that they have not yet noticed or taken charge of the fact that they also have a hearing loss. So tinnitus almost always occurs with a hearing loss. Sometimes the hearing loss is not great, but it almost always occurs with a hearing loss. So let me back up for a second. What kind of problems has tinnitus created for you? What kind of challenges do you have?
Sleep.
Sleep? Anything else? Focusing your attention? Okay, anything else?
Concentration.
Concentration? Anybody upset by their tinnitus?
Yes. Anxiety.
Anxiety,
Depression.
okay. Anxiety, depression. Anything else?
Aggravation.
Aggravation, get upset by it.
Concern it's going to get worse.
Concern it's going to get worse. Okay, so let's see how we matched up here with the survey. So, interestingly, 45% of the people say it really doesn't have any effect on them. Now, that's not true, and I said this to someone today. I actually did got a small grant a few years ago from the University of Iowa. They had an alumni newsletter, and in the alumni newsletter, they had a paragraph about this grant that I had on tinnitus, and about 4 or 5 pages. This went around the country to alumni. And within the next 2 or 3 weeks, I had 100 emails from people. And they all said pretty much the same thing. They said, I have tinnitus, I've had it for 10 years, and it doesn't bother me. But if you know how to make it go away, I will fly to our city next week. And that kind of surprised me, actually. I wasn't really expecting that. That kind of surprised me. Does anybody think their tinnitus interferes with their hearing ability, over and above their hearing loss? Okay. Some people tell me they have to listen through their tinnitus, or they have to hear over their tinnitus. Sometimes they confuse the sounds with their hearing loss as well. Confuse the sounds with their tinnitus. So sleep is one of the most common ones. Concentrating and getting upset. I call these other things, leisure activities, social lives, and work, personal relationships, secondary effects. Okay, we'll come back to that also. So now we'll talk about the mechanisms, and there are probably several mechanisms. So it has to be related to what we call spontaneous activity in the nervous system. That is, there's activity going on spontaneously without any sound coming in, but when those nerve fibers are active in a way that they shouldn't be. And of course, there's nerves throughout the whole body and all over the brain, and nerves going from our ear all the way up to the brain. And all these nerve fibers are attached to each other, connected. And they're connected at these neural junctions we call synapses here. And there's one neuron going to the next neuron in cell bodies. And there's these synapses all the way. These synapses and these nerve fibers carry the information from one to the other. So these nerve fibers are transmitted. It's like transmitting what I call electrical impulse, like a flashlight going on and off. And they're translated from one nerve fiber to the other at these impulses. And they're regulated by some chemicals at the junction between the two nerve fibers. And that's true in the cochlea, where we have hair cells. And that junctions all the way up to the brain. And there's different kinds of chemicals at each of those junctions. Some of them make the nerve fibers more likely to be active, and some of the chemicals make it more difficult to communicate from one nerve fiber to the next. So it's quite as sophisticated, and of course there's hundreds of thousands of these all the way up to the brain. So it was noted a long time ago that some people had tinnitus in their left ear, and they were really upset by this. And they would go to a surgeon, and the surgeon would actually cut the ear, cut the nerve fiber going up to the brain from that ear. That's how bad their tinnitus was. So they gave up hearing in that one ear. And it turns out that they were only successful in about 30% of the people. So they stopped doing that, but it gives you an idea of how desperate some people were to go through that procedure. It also tells you how much we really don't know. Sorry, I'm moving around where I'm not supposed to be. It also gives you an idea how little we know about tinnitus. For example, some other indications were that people could hear tinnitus in their left ear, and we did some experiments early on and put a noise in that ear to try and make it go away. And I remember the patient said, "Oh, that's wonderful. I can't hear my tinnitus anymore in my left ear, but now I hear it in my right ear." So it was probably there all the time in both ears, but it was louder in one ear than the other, and they lateralized it to the one side. We also discovered, much to our surprise, that even though somebody heard tinnitus in their left ear, for some patients, we could put a noise in the right ear at a very low level and make their tinnitus go away. And the notion was that even though they hear it in one ear, it still might be mediated and controlled by something going on up in the brain that has activity from both ears, obviously. So that was something we discovered early on, that the central nervous system has to be really active in this. So there's three different, at least the way I think about this, there's three broad areas, three broad categories of what causes tinnitus, what the mechanism is for this. Okay? And keep in mind, there's a spontaneous activity going on in the auditory system all the time. So one theory is that it's simply increased spontaneous activity. So, for example, here's a hearing nerve, and that hearing nerve, even without any sound, has a little impulse, a little electrical activity that goes on that hearing nerve. And that's even without any sound at all. When we say a word like table, then some of the nerve fibers get really active. And of course, there's 20 or 30 of these 20 or 30,000 of these nerve fibers in the nerve. And when a bunch of them get activated all at the same time in a similar fashion, the brain's up there saying, "Oh, somebody just said the word table." So that's basically how we can hear and understand speech. Well, it may very well be that some of these nerve fibers are hyperactive, even without sound, and the brain's doing what it's supposed to do. It's interpreting that activity on those nerves as a sound. So as I tell patients, your brain's doing what it's supposed to do. It's interpreting all that hyperactivity on those nerve fibers as a sound. I hear a whistle. I hear a tone. I hear a noise. So it depends on that activity. So that's one clear theory. The other theory is that there's lots of nerve fibers, as I said, and usually those nerve fibers are independent. So there's we call these action potentials, activity on this nerve fiber but not on this one, and activity on this nerve fiber but not on this one. But what happens if they were all firing at the same time? The brain's going to say, whoa, there's something really different going on here, something special. And that might happen because of something like this. And actually, so here's the nerve fiber here. The nerve fiber is covered with a sheath, sort of like a rubber sheath around the electrical wire to keep the activity on this nerve fiber separate from this one. Well, if the sheath is damaged, then maybe an electrical signal traveling down this nerve fiber gets picked up by another one when it's not supposed to, and they fire at the same time. And actually, that was proposed first by Aggie Muller, who's actually from this area. So the other way of thinking about this, the third category of mechanisms responsible for tinnitus, has to do with the brain reorganizing itself. And the way that I think about this is that you have a hearing loss at 4,000 hertz, or 4,000 cycles per second. And what happens is you lose hair cells in the cochlea. And everybody's here has had their hearing tested, right? I sure hope so. So you would have been explained, the audiogram would have been explained to you and how it relies on the cochlea in part. And the hair cells in the cochlea would disappear at 4,000 hertz if you have a 4,000 hertz hearing loss. Well, what happens is that the nerve fibers attached to that part of the cochlea, the end organ of hearing, start to disappear. But the part in the brain that responds to 4,000 hertz doesn't disappear, it's still there. that part of the brain at 4,000 hertz is now not getting any input. And what happens is that that part of the brain starts to respond to 3,000 hertz instead of 4,000 hertz because it's sitting there doing nothing. So now there are two parts of the brain that are responding to 3,000 hertz. So there's too much spontaneous activity at 3,000 hertz, and the brain says, hey, there's a 3,000 hertz signal up here. I hear a tone at 3,000 hertz. And that's the third way that we think about the mechanisms of tinnitus. And the analogy from that comes from this neuroplasticity. So for example, if you lose a finger, the part of your brain that used to respond to the finger doesn't get that representation anymore. And what happens is that part of the brain starts to respond to other parts of your hand. So you have an over-representation in that same area. So it's also important to think about tinnitus in terms of two parts of it. So you have tinnitus, it's a signal going on in your brain that's not supposed to be there. But you also have your reaction to the tinnitus. So you have your tinnitus, and you have your reaction to the tinnitus. So your tinnitus might be low pitch or high pitch. It might sound like a roaring. It might sound like a buzz. It's often different in different people. And people, the annoyance people get from that, the reaction that they have can be quite different as well. And of course, all of us have stress in our lives. We all have challenges from here to there. And some of us are quite good at dealing with stress. Some of us don't like to see spiders. We get upset by that. We're all different about dealing with different things. And of course, the more upset we are in general, the more anxious we are in general, whether we have tinnitus or not, the more upset we're going to be by the tinnitus. I hear some people say that the loudness of tinnitus doesn't matter. I hear some researchers say that, and I think that's wrong. If anybody here would prefer to have a louder tinnitus, please raise your hand. So within an individual, it matters a lot what your tinnitus sounds like and how loud it is. You do correlations across lots of different people, and the correlations between estimates of loudness and annoyance aren't always high, but that's because you're asking different people to answer the same question. So I've been doing this for a long time, and eventually I grouped the primary reactions of tinnitus into these four areas. So tinnitus can have an effect on your thoughts and emotions, can have an effect on your concentration, have an effect on your hearing, and having an effect on your sleep. Now it turns out everybody's different. So a lot of patients are not bothered at all by their sleep. And other patients, that's the worst thing. The sleep is the most common complaint that patients make in my experience, generally. Anybody here have difficulty going to sleep at night because of their tinnitus? Raise your hand. Okay, so a few of you. Anybody here not bothered at all when they try and sleep because of their tinnitus? Okay, that's it. Differences. Okay, so that's important to keep in mind. The annoyance is influenced by the tinnitus itself, by the patient, and it's more annoying generally if it's louder, if it's a narrower spectrum, more focused in frequency. If you're under stress, if you haven't had enough sleep, your reactions to that are going to be magnified. So now I want to talk about measuring tinnitus, because we don't always appreciate that it can be measured. Has anybody here had their tinnitus measured? Would you like to share? How was it measured?
They did several different types of hearing tests.
Different hearing tests.
Speech recognition.
Okay.
And,
Okay. So you tones is one way. Anybody else? How did you have your tinnitus measured? Pitch matching. Okay.
Same.
Okay. So the way that I think about tinnitus is that it's a signal in your head somewhere, and that we should be able to make the same basic measurements on tinnitus that we can of some physical tone. And so the basic properties of a tone are its pitch and its loudness and the quality of it. So we can also do things like mask it, and I'm going to just talk about those three things minute. So we have the tinnitus. We're going to try and measure the tinnitus itself with those pitch and masking and loudness. And then we have the reaction to tinnitus. And we can try and measure that by different questionnaires, for example. And then sometimes people studying this also measure their psychological tests about how upset you are, about how anxious you are. So there's lots of different ways of trying to get at what's going on here. So for the pitch, what I say is, I'm going to let you hear my tone, and I want you to adjust the frequency of my tone so it has the same pitch as the most prominent pitch of your tinnitus. Now, I chose my words carefully. Your tinnitus might not sound like a tone. It might not even have one pitch. But most people, not everybody, most people can adjust my tone so it has the same pitch as the most prominent pitch of your tinnitus. Not everybody, and it's quite difficult. It's quite variable, but you can do it. I want you to adjust the intensity of my tone so it has the same loudness as your tinnitus. Okay? Fairly straightforward. I want you to adjust the level of my noise until it just covers up your tinnitus. And we call that the minimum masking level. Some people, we can't mask their tinnitus for some reason. It's different. It's not like a pure tone. In a normal listener, we can always mask it. But for some reason, for some people, we can't seem to mask the tinnitus. So there are some differences. It's not like a real acoustic tone. So now we'll mention the reactions that people have. So these are some of the things that are often come to light. Now, I like to have control over everything in my life. Unfortunately, it doesn't work out that way very often, but I really do like to have control over things. And so what happens if you have a sound in your head and you don't have any control over it? It's not supposed to be there. Is it going to be there forever? Is it going to get worse? Does it mean I have some illness? These are common reactions that people have. Common reactions that everybody has, usually, when this first begins. It turns out the biggest problems people experience usually occur in the first 3 to 6 months after they first started. And after about 9 or 10 months or a year or so, then sometimes the reactions wane away. So we say people that seem to adapt, because a lot of people have tinnitus, like I said, that called me after they read the alumni newsletter. It doesn't seem to be a big factor in their life. At least that's what they said. So the onset, they're concerned. They ask questions. They might try some coping strategies. And then eventually they realize it's there. It's not good or bad. I can't control it. Lots of people have trouble. They focus on other parts of their life. They're still aware of it occasionally, but they seem to have habituated to it, as we say. This takes time to adjust to unpleasant experiences. And if we're stressed out in our lives, it might take more time. But in time, these people seem to be able to manage their symptoms. Right? Everybody's different. Those patients who do not adapt, they have the same initial reaction. This is terrible, it's not fair, I'm upset by this. They interpret their tinnitus as being significant. They start asking questions, they try different strategies. Their attention does not decline. In the long term, they become even more aware, they become anxious, they're depressed by it. We sometimes talk about being in a vicious cycle. The more you're upset by it, the more you think about it, the more you think about it, the more upset you get. And it can become a real problem. There are secondary things about people becoming depressed and anxious. And again, you can control your reactions. You have your tinnitus. You might not have any control over that. You can control your reactions. Okay? So there are some things that you can do to change how your reaction. And these fears and worries can be helped, and others can have done this and made it less important in their life. So can you. So sometimes as audiologists, I'm an audiologist, so sometimes we think we know the answer. We have a plan. We're going to provide you with hearing aids. You'll hear better. We know that you can just do this. We have an idea of what's going on. But that doesn't always work out for tinnitus because everybody's different and everybody comes from a different background. And it's really important, especially with tinnitus, to try and understand what's going on. Not just with the tinnitus, but with the individual patient that we're trying to help. Does anybody experience loud sounds as being really loud? Have one hand back there, 2 hands, 3 hands, 4 hands. Okay. So we tend to call that hyperacusis. And I refer to this as 4 different kinds of hyperacusis: a loudness hyperacusis, annoyance hyperacusis, a fear hyperacusis, and a pain hyperacusis. So for example, some people get so annoyed, and for some people it's just some sounds and not other sounds. Some people get so annoyed by some sounds, and if some sounds are so loud they decide not to go to church or not to go to a football game or not to go to a restaurant because of their hyperacusis. It seems like a lot of people who have tinnitus also have hyperacusis. So it's fairly common for these things to occur together. So there must be some common relationship, at least in some of the people. Okay, so there's work done on the loss of control and how important that is. So I also think about this, and I have a friend from Denmark, Anna Moore, who's a clinical psychologist. And actually, remind me at the end that I've got a book out that I edited on self-help, and she wrote a chapter on this. It has to do with accepting things. So as she would say, the tinnitus isn't good or bad, it's a sound. And so some of her patients are just saying, accepting this. This is my sound. And that's different from being overwhelmed by it. I can't stand it, this is terrible, it's awful, I don't like it. Overwhelmed by your tinnitus. What we typically try and do is we try and help patients control it to make it less important. And a lot of patients actually benefit from wearing comfort sound therapy, from wearing comfortable sounds that help them adjust to this and decrease the prominence. And we're going to talk more about that in a minute. I also tell patients that, because a lot of people come in, has anybody looked on the internet about cures for tinnitus? Raise your hand. Boy, what a surprise that is. So, the more you're thinking about your tinnitus, the more you're thinking about your tinnitus. Right? So a lot of patients come in with a long list of things, with lots of questions, and that's okay. But keep in mind, we're trying to, you're trying to control this, and that's okay. 3 different reactions: defeat, overwhelmed by it, controlling it, and that can be a helpful thing, and accepting. To separate the tinnitus from your reaction to it, and you can control your reaction. My job is here to help you. Okay? So, medications and dietary supplements for tinnitus. Has anybody tried a dietary supplement for their tinnitus? What have you tried?
A long list of
A long list, okay. Anybody else?
Vitamin D.
Vitamin B, anybody else? Zinc? Lipoflavonoids? Anybody else?
I have a different compound that actually works from the house clinic that is patented only by HAPS. You can't buy it any.
Okay.
It's made at compound pharmacy.
Okay, can you give us a little secret hint what it might be?
I think it's different. It's different than the lipoflavonoid.
Yeah.
It has the ascorbic acid in it is time release, and that's different. It's a bunch of different. It's slightly different from it. And I went out to California, and it's interesting. They can't. It's so patented that they cannot do it in Dallas It's actually, it's not done by house, but in California, they have compounding pharmacists
Okay.
that know how to do it.
So one of the interesting things about this, I'm gonna say that, that I'm glad that it's helped you. That's a wonderful thing.
Not 100%, but it's better than.
Okay,
yeah.
so that's great. And I'm going to come back to that in a minute. One of the amazing things is that every now and again we see a patient who says, I take this supplement and my tinnitus is really helped by it. Okay? Now, there has been no study that has been done and replicated by this. It's been carefully done. It's shown that any dietary supplement or medication helps with tinnitus. Now, it doesn't mean that it can't help in some individual people because there's different mechanisms. We're all different. The dangerous thing about saying that to patients, and I do that, I have a group session once a month. The dangerous thing about saying that is that a lot of people spend a lot of money, they go to a lot of places, and they're constantly looking for that cure. And it might not be there. As long as you're thinking about your tinnitus, you're thinking about your tinnitus. So this slide right here, in the group session, I will say that there's no medication or dietary supplement that has been shown to be effective in a controlled study to reduce or eliminate tinnitus. And then I pause for about 5 seconds, and I say, in my professional opinion, there has been no study that's been replicated with the right kind of controls, with the right kind of metrics, that has shown that anybody can offer you a drug or a medication to help you with your tinnitus. So I say that twice. Now, there are drugs that will help you with anxiety and with depression, and there are drugs that will help you get to sleep. And those are all good things. That's okay. Nothing wrong with any of that. But right now, there is no drug or medication that has been shown to be effective in treating tinnitus.
We'll add one thing that they do that's a little different to that, to supplements. They have you take 50 milligrams of niacin, where you will get the flush on an empty stomach twice a day. The theory behind it, again, same thing, just the theory behind it is it helps the circulation in the brain. And so that's something that they, if it doesn't, if the supplements don't work, then they add the niacin.
Okay. Well, and again, I'm glad that works for you. I'm going to emphasize once again that that has not gone through any controlled investigation that has been published in any peer-reviewed journal where anybody can say this helps some patients with tinnitus. That has not been done. I'm glad it helps you. That's wonderful. Okay. Yes.
Are you aware of this? This just came out.
So my experience
is
is
by FDA approved. This just came out. My EMT didn't even know about it yet. Do you? And Cedars-Sinai is going to be training with Cedars in New York.
So I'll talk about this in a few minutes.
Okay.
Yep. Another question or comment?
Yeah, this is a generic question. You said no particular drug has been shown to be effective in studies. How does one, if one comes up with a drug, begin to test in one of these studies? You know, in other words, the researchers can't possibly have researched every possible combination. So how would, if somebody says, hey, this works for me, and they want to have a study, who would conduct that study?
Right. Well, there's the most common way that this occurs is that somebody comes up with an idea, and maybe from personal experience, and they connect with a dietary supplement company or a drug company, and they actually try. We call it open trial. So we get 50 people, and we give them a drug or a supplement, and see if it works. We make some measurements before. We give them the drug for 2 months. Make some measurements at the end, see how many people report a benefit. And the problem with doing that is what's called the placebo effect, right? Is that a lot of people, now that they're engaged, people are paying attention to them, they're in a trial, good, this is a wonderful thing, this is going to help. So that kind of trial is not sufficient to convince the FDA or the healthcare community that this drug is effective. But if there's enough people in the open trial that benefit, then somebody's going to say, wow, this actually might work. Now we'll do a controlled trial. And the best kind of controlled trial is what we call a crossover design. So we get 50 people that get the drug and 50 people that get a placebo pill. They take it for a month, and then the 50 people switch. And they don't, the people don't know whether they're getting the placebo or the drug. And ideally, the people that are doing the experiment don't know either. So that's how these things are evaluated. Yes?
So number 3 says there are promising medications under study. Are they being tested in this way?
They are, yeah, in both ways, yes. Yeah. And interesting, I had somebody call me last week that is, has a company that does a dietary supplement, sort of, and I won't tell you what it is, but he has really bad tinnitus, and he wants to do a trial. And he's, I don't know how this is going to work out, but he's prepared to give 1,000 people this drug, this whatever it is, I can't even tell you what it is, and then to make some measurements a month later or 2 months later and to see in the open trial if it actually works. Because he really wants this to happen.
So can I volunteer?
Not yet. So, but there are lots of, because there are so many people in the world with tinnitus, and because there's no cure yet, there are a lot of people interested in making a lot of money from finding the right pill. And that's okay. We just haven't found it yet. So the same thing is true for alternative medicines. Alternative medicine is alternative to treatment. Interestingly, I didn't know this at first, that the FDA doesn't regulate dietary supplements. Okay? So the idea is that they're not prescribed by a physician, therefore they don't have to be regulated. And as long as they don't hurt anybody, and some of them do, then it's okay. If they start making claims, and some of them do, then the FDA usually doesn't get involved, but somebody might sue them. And that's how they change how they present their labels. And this is actually a few years old now, but it's incredible how common taking complementary medicines are throughout the United States for all kinds of things, and not just for tinnitus. So raise your hand if you tried a dietary supplement for your tinnitus. Okay, so not that many. So some. All right. How many people here have hearing aids? All right, great. So it turns out that I think that hearing aids are an incredible bargain. I've heard a lot of people say how expensive hearing aids are. Hearing aids are not expensive. Hearing is one of the most important things that we do. It enables us to communicate with other people and to interact with other people and to socialize and think about the future and look forward to tomorrow. Hearing is really, really important. So when you buy your hearing aids, and we're all going to need them eventually, make sure you get excellent hearing aids that are well fit, because hearing is really, really important. It turns out, fortunately, that hearing aids often help tinnitus. So they help tinnitus probably because they improve communication and therefore reduce stress. Some hearing aids amplify background noise, and that can actually be a good thing for tinnitus patients and provide some distraction and partial masking. So this is a survey where we asked people who used hearing aids if it actually helped them with their tinnitus or not. And about half of them said no, it had no impact whatsoever. And so that's okay. This half over here. And 4% of them here said it actually made their tinnitus worse. So keep in mind. Now actually the hearing aids can be adjusted so that doesn't happen. So it's possible to turn the maximum output of the hearing aid down for a while and gradually increase it slowly. But most of the people, or half of the people here also said that using their hearing aids helped them with their tinnitus. Did I turn it off? Yeah. Okay. So hearing aids are wonderful. They improve communication. They reduce stress because you don't have to listen as hard. They amplify background sounds. And for a lot of people, actually, when they turn hearing aids off at the end of the day, because their auditory system has been activated for a long time, their tinnitus is actually gone for a while, even when they're not using their hearing aids. Those of you that have hearing aids, does it help you with your tinnitus at all?
No.
So here's a yes, one no,
No.
one no. Okay. So in addition to hearing aids, there are wearable sound therapy devices for tinnitus that produce a variety of different sounds these days. And these are often very, very helpful to lots of people. And of course, these days, does anybody have a little, let's say, a cell phone with them? Probably. Well, of course, these people, this was heard here from the beginning, these are actually computers. And we all have computers now, and almost all the computers we can talk with and take pictures with. And some of the small computers are also used as one of the apps as a telephone. So they're all doing the same thing. A lot of these computers, including our cell phones, can also produce sounds. And you can search for apps that'll help produce sounds for tinnitus. A lot of people listen to these sounds, and a lot of people benefit from them. So it turns out that a lot of the hearing aid companies now, and some not hearing aid companies, actually produce wearable devices, often like hearing aids, that produce sound. And the reason they do this is because people buy them because it helps them with their tinnitus. So 10 years ago, there were 3 or 4 companies doing this, and now there are 15. Because they're making money, because people are buying them, because they benefit. So they're actually very helpful. This is an example from a friend of mine from New Zealand. So often people will say that their tinnitus sounds like a cricket sound. So there's your cricket. This is a visual analogy. And some of the sounds that go on are like these waterfall sounds, that broadband, comfortable noise, okay? So some of you may not have realized you still have your tinnitus. So that's the visual analogy of taking away the prominence of that sound. The different sound therapies that have been tried over the years differ mostly in the level that's used and in the quality of the type of sound. So Jack Vernon from Portland first proposed this, and he suggested a total masking where the noise, the background noise, the comfort sound, covers up the tinnitus completely, and the person listens to this sound, the noise, let's say, for example, or waterfall sound, and they listen to that instead of their tinnitus, like a whistling, screeching sound. And for a lot of people, that's wonderful, and a lot of people enjoy and benefit from this total masking approach, because it's easier to listen to. However, for some people, that's too loud, and they don't like it. And so a lot of people would prefer a lower level of sound, and we call that partial masking, where you hear the tinnitus and you hear this background sound. But your tinnitus is no longer as prominent as it was, and actually you can reduce the loudness of your tinnitus by having a low-level sound in the background. We call that partial masking. So now there's lots of options. 10 years ago, there was only 1 or 2 options. Now there's many options to listen to and choose from. A broadband noise like a shh. You can modify amplify the high frequencies or low frequencies. You can change the envelope. You can have tones, process music, modulate the tones like you're in a spa. You can adjust the noise depending upon your individual audiogram. You can actually, there's some devices now that based on some theoretical issues where you can notch out certain parts of the sound so that you hear some regions of your auditory system get activation and other parts don't get activation. So lots of different options now because people like them. The kind of therapy that we do with this, and we recommend the counseling with all of our sound therapies, we refer to as Tinnitus Activities Counseling. And this is one of the slides that Anne Moore from Denmark suggested to me. So this is all a bunch of pictures, and we actually go through and sit down with patients with this. We started with a study I did many years ago, and I wanted to control it. So I wanted all the counseling to follow the same protocol. It actually helped me because sometimes I realized that a patient left and I forgot to say something really clever that I said to the patient yesterday. So this helps me keep organized myself. And one of the things Anne Moore helped me with was she said to her patients, where do you want to start? Because we're all different. And some patients have a lot different problems than others. And sometimes it's not necessarily related to their tinnitus. She's a psychologist. What do you think caused your tinnitus? We talk about spontaneous activity. These are just some of the slides that we show. Doorbell goes off. Doorbell, no big deal. Doorbell goes off. There's a fire next door. The next day the doorbell goes off and there's been a car accident. The next day the doorbell goes off and your tree has fallen on the neighbor's lot. The next day the doorbell goes off and you're thinking, oh no, now what's going to happen? 2 weeks go by, the doorbell goes off and someone sends you flowers. The next day the doorbell goes off and it's a friend. The next day the doorbell goes off and someone has sent you a prize. The next day the doorbell goes off and you're thinking, wow, this is cool, now what good is happening? It's the same sound, it's the same doorbell, but people have quite different experiences, and that has an impact on the kind of reactions that we have. And this is true for all of us. And this is part of what they call cognitive behavior therapy. And when we designed this treatment many years ago, we used some of the principles of cognitive behavior therapy to help people understand how they think about things could have an emotional consequence on them. Well, I'll leave up here afterwards. These are 2 books that are self-help books that we give out to our patients. This one is hard to get these days, but this is from 2 psychologists from Australia. I think this is the best book ever written on tinnitus, actually. It's very structured. It's chapter 1, you do this, chapter 2, you do that, chapter 3, you do this. And it guides people through one step at a time. This is the other book that I edited, and I should confess that I make about 4 cents every time one of these is sold. But this is based on different chapters. So I invited people from all around the world that I thought could do a good job. This is a chapter on hearing aids, there's a chapter on medications, there's a chapter on medical workup, there's a chapter on sound therapy, a chapter on mechanisms, and so on. Okay, I'm going to finish off by talking about some aspects where I think that the future might lead us. And I think there's a couple of options here. And one is that there will be a cochlear implant for tinnitus someday. So there are a lot of patients who get cochlear. Has anybody heard of a cochlear implant? Anybody know anybody with a cochlear implant? So a cochlear implant is an electrode that goes into the cochlea, behind your eardrum, the inner ear where the hair cells and the nerve fibers are, usually for people that are totally deaf. That's where we started initially. Over the years, people with more moderate hearing loss are now getting implants. And actually, my first job was in England, and I came back to work in Iowa to help start the cochlear implant program. And I thought my job was to show that cochlear implants did not work. And I was wrong again. fortunately. So it turns out that some patients get cochlear implants and they say, well, I can hear so much better now, thank you. But even better than that, my tinnitus is gone, or my tinnitus is reduced. So now there's lots of interest. I've been trying to get interest going in this for a number of years. Now there's lots of interest in using a cochlear implant. So this is a single patient. This is over a month. These are different days. And we had them rate their tinnitus loudness. So 0 is gone and 100 is the worst loudness they can imagine. This person had a hearing aid in one ear and a cochlear implant in the other ear. And we had them rate the loudness of their tinnitus every day in their hearing aid ear, which didn't change very much. And in the other ear, they had their cochlear implant. The cochlear implants have different electrodes, and this one had 20. And on electrode 1 and 3 and 5 and 7 and so on, they have their signal from the environment, their microphone from the speech and the environmental noise was all presented on those electrodes to help them hear better. And on the other electrodes, 2, 4, 6, and 8, we presented the signal that we thought might suppress their tinnitus. Okay? And they alternated every single day between those two different signals. So the good news is that their tinnitus was reduced by both of these signals, and it turns out it was better on one than the other. So I think that there will be something in the future, but it's taken a long time. The other approach, and it turns out this approach is being done with vagal nerve stimulation, which has been shown to be effective for epilepsy. And I recall the first time I saw this at a meeting in Washington, D.C. And the vagal nerve that's used is usually in the neck. And here's a picture of that. And I saw somebody showed me a videotape of somebody with epilepsy going like this. And then when he flipped the switch, so I was overwhelmed by this, and now I'm glad to say that I'm involved in a study, as is sites in Buffalo, Detroit, Dallas, Iowa City. So there's work now going on pairing the stimulation of the vagal nerve, which has the potential to change how your brain is reacting and coding the tinnitus signal as a treatment for tinnitus. So that trial is underway right now. All right, so I want to finish here. So here's the screen. It turns out that I was in a coffee shop about a month ago, and this is the wall of the coffee shop here. This is a window in the coffee shop, and sure enough, here's the screen. Well, it turns out that I was wrong once again. Oops, let me back up a little bit here. Here's the coffee shop. There's the table I was sitting at. It's a painting on the wall. So here I thought all these years this guy had tinnitus. He spilled his coffee. Awful. Okay. So we also have a meeting in Iowa City every year. We're going to have the 23rd annual conference, and actually we invite patients as well as professionals. So we usually get anywhere from 8 to 10 people from around the country, and you're all welcome. Okay, are there any questions?